At Capella University, you're in control of your education. With the game-changing FlexPath format, you can set your own deadlines and move at your own pace. The faster you move, the more you save. Visit capella.edu to learn more.
Holidays are here, and so is fashionable fitness. Gift yourself a Samsung Galaxy Z Flip 3 5G, a phone that folds in half to literally stand on its own. Pair it with the Galaxy Watch 4 for ultimate wellness and wow factor. Check health stats, flex personal records. Over 90 activities can be tracked, like biking, swimming, golfing, and more. Invest in yourself with tech made to crush goals. Holidays open up with Galaxy. Shop it all at Samsung.com. 5G connection and availability may vary. Check with carrier. Products sold separately.
So maybe one of the things that I'm kind of looking at is, why do we approach these diseases with such caution first? And as each variant comes out, we don't just breathe a sigh of relief that it might be less deadly.
Here's an interesting thought. I would much rather have a virus that is way more deadly and way less infectious than a virus that is way more infectious and way less deadly.
It is time now for something positive.
We might be headed to the promised land,
speaking the truth
and finding our external liberty once we internally liberate ourselves.
The problem can only be solved when there is a kind of coalition of conscience.
Because that is how it works. This is the beginning, it is not the finale, and that's why we're here, and that's why we rally.
We've got to be that creative minority.
Find a way to get in the way. I got in trouble. It was good trouble. It was necessary trouble.
Frankly, I know we've got to do something.
All right.
And welcome back. Hello, everybody. Welcome back. It's Thursday, the 16th of December. We are going to be joined by our favorite infectious expert, Dan. See how
the
I say
man with
that?
an infectious intelligence and an infectious smile.
He's my Superman.
Can you guys hear me okay?
Yeah, buddy.
Sure.
I'm just trying to sort out some audio on my end, so just give me 1 hot second, so feel free to keep chatting. I apologize.
No problem. You can find Public Access America anywhere you find your favorite podcast, and you can find this on our live streams every Sunday, noon Eastern, 9 a.m. Pacific on YouTube. So I had one question, and then Jeffrey has a whole bunch of questions. I did ask for the full Dan today. I'm excited about that one. I'm tired of dumbing down this conversation. It seems like every media agency does that with either denial or hysteria. And I just kind of wanted a really fact-based, great. I want homework when I'm done with this, but I only have one question ahead of all that for Dan when he's ready.
It better not be whether or not a booster can give you a big pee-pee.
No. I just want him to tell me what my holiday protocols are before we get into everything else, like what I should be doing, looking out for, asking other people to do ahead of the holiday. I don't want to walk in. I don't want to walk into a COVID bomb. So how do I
don't string the ornaments together to create your own homemade set of anal beads.
Oh, but they light up.
You don't want those to break. That seems like a bad idea.
It's the only way idea. It's the only way I can afford a PET scan. You know what I mean?
Did you guys see? Oh Lord! Did you guys hear the story? There was a guy in England. No, it wasn't England. It was some guy who found a mortar, an unexploded World War II mortar, and decided to put it up there. And then bomb squad on the hospital.
He found it. Yeah, he found it. He didn't. I didn't know he admitted to actually.
No, he said that he accidentally sat on it, and I'm like, no. Look, there's a lot of things I've accidentally sat on, but it has not ended up on my ass.
2 words. Okay, holiday planning. Some public safety guidance. Flared base, everyone. A flared base.
We did that in a couple episodes ago, right? Like flare your butt plugs. Honestly.
Yes.
What wonderful way to start off the holiday season is talking about
Yeah.
And stretching with a bomb. Yeah.
16% of everything that went up the rectum accidentally was live ammunition. That was something I took away from that.
Are you kidding me?
And 30% was stuff
Wow.
in the ear, I think.
So what you're saying is amosexuality is now actually a thing? Oh God.
Amosexuality. I love that.
So don't get me wrong. I love shooting off a good rifle. Like I'm a big fan. You know, I get to do it every once in a while, but I've never once had the thought of, you know what, I'm going to take this thing that is explosive by definition, and put it into my body. Right. I feel like the whole point of an ammunition is to put it into another body or into a target, but not to your own.
That's right.
Yeah.
Well, I mean, there is the TikTok challenge that's been going around lately. That's a revival from the old challenge back in the day, called "Bointing a Loaded Gun at My Venus."
No.
Why?
I got to watch somebody win a Darwin Award because, well, they're never going to be able to reproduce, but they definitely ended up a toothpick and 2 olives short of martini.
Oh, no.
Oh, my.
It's not the suppository, it's the delivery device. Anyway, Dan, ahead of the questions that Jeffrey had, and I love it, I just wanted to ask you what my holiday protocols should be. You know, people are just tuning in, they want to know. So ahead of Omicron and Delta and COVID and everything else we're worrying about, what should I ask other people to be doing for me ahead of the holiday? And what should I be doing for other people ahead of these get-togethers?
That's a good point. So at this point right now, with the way the vaccination works for COVID, if people are not vaccinated right now, if they go and get vaccinated right now, they're not going to have like perfect protection. But if people are unvaccinated and you're planning to spend time around them with the holidays, I think it's a very reasonable thing to encourage vaccination if they're medically able to get it. And if you're not sure of the company that you're going to be keeping, if they're vaccinated or not, I mean, it is well within your rights to ask if they're vaccinated. They don't have to answer, but I think it's important to keep that in mind because even though, you know, there's all this stuff with Omicron going around, but even with or without Omicron, Delta being the predominant variant in the United States is still very dangerous. And actually, I just got off the phone with a friend just a few minutes ago. Two of his family members died of COVID in 3 days. And what happened was one of them was careless. One of them thought he had a minor cold. His spouse went to go visit some in-laws and, you know, oh, no big deal. I'm feeling fine. My husband feels sick. So they went, but I feel fine, not knowing that they could be an asymptomatic carrier. Sure enough, asymptomatic carrier from point A to point B, and now 2 people are dead and another one's in the hospital. So the reality is that you don't have to feel sick to spread COVID. And even if you don't feel like you're sick, you might also, it takes a while for us to recognize that we are sick. So it's really important to be mindful be careful of who you're spending time with. Understand that, you know, masking and distancing and hand hygiene only goes so far. The vaccine is an amazing tool. Be very, very careful this holiday season. I know that people are kind of thinking COVID's over. It's not over. And this still remains a pandemic of the unvaccinated. The people who are unvaccinated are the ones getting whacked really hard with severe cases, with hospitalizations and ultimately deaths. That's just really not happening nearly as much among those who are vaccinated. So I keep pressing the vaccine thing because the data supports it. Be responsible, be mindful, ask for your own safety and for the safety of your loved ones. So
right.
That's kind of my brief summary.
It's okay to avoid a get together because people refuse to get tested or vaccinated. You can get tested. You can get tested ahead of a get together. I think I've heard about that for a lot of Christmas get togethers. There's requests that people are tested on site the day before they come in.
I've seen a couple of those.
So
and you can get the rapid at home test. The one thing to keep in mind is that asymptomatic testing. If you're not feeling any symptoms with those tests, you can have a pretty high false negative rate as well if you're actually an asymptomatic carrier. So a negative test is a reassurance. It is not a guarantee.
Okay, fair enough. Still, avoiding is the best issue.
Yeah, I agree.
Just for this year, I mean, Dan, you got engaged in this pandemic. You got married in this pandemic. So there's safe ways to do it, obviously, but people need to put the thought into the safety ahead of time and not the regret afterwards.
Absolutely. And we very heavily modified our wedding plans and basically stayed with our own bubble because that was what worked and was safe and was responsible. And we were fortunate to have access to the vaccine as well. So, I mean, that's... Yeah, it sounds like old hat. It sounds like just, you know, playing the same piece of music over and over again, but it really does work. The testing, the being careful about who you bubble with, being responsible, the hand washing, the masking, the vaccinating, it works. Yeah. But it's not. There's no one fail-safe approach. You have to be careful and be responsible with all of it.
At least you're alive to warn us, and I'll leave the rest. I'll leave the rest to Jeffrey.
Yeah, and that's. I mean, even looking at data from CDC, I mean, there was a bunch of really good information that came out this last week. Unfortunately, I'm not going to get into the political side. We already know what that looks like. I'm going to go strictly with, something that is not political, but being vaccinated versus not being vaccinated. This is not a political thing. It should have never been a political thing. But even the data supports the fact that, like, right now, people who are unvaccinated are 14 times more likely to die than people who are vaccinated. It's not perfect, but when you look at what the data supports, it's very clear. Being vaccinated is your best bet to staying alive.
And boosters.
Boosters are going to be an interesting one.
Yeah, I agree. I think it's really interesting that we as a society hold vaccines to such a higher standard of efficacy or perceived worthiness than most other medications as well. Like, you talk about how many people are on statins to control cardiovascular disease and cholesterol levels, like Lipitor. How many people are on Cialis for erectile dysfunction, right? There's all kinds of no comment about whether or not Jason raised his hand. All these medications that we just take for granted are on the whole way less effective and have way more side effects than most vaccines do. But I guess it's maybe something to do with the fact that it's injected and it's not like for something that you have or is diagnosed with. It's not a treatment. It's kind of a prevention. Whatever the case is, people hold it to a way higher standard, but the reality is that they work. And even if they only worked 50% of the time, I think it's still worthwhile. So yeah.
Agreed.
Jeffrey, I hear it sounds like you have much more to talk about or many more questions for me. So fire away, my friend.
I've got plenty of questions for you. Being someone that reads a ton, I recently had the question about boosters because, one of the things that I had read was, whether or not you needed a booster. There's been a lot of studies out there about people who've had COVID and then got vaccinated, have super antibodies and have a much higher antibody count than most people. Very, very just anecdotal note here. My mom had COVID, got both shots of Moderna, went and got an antibody test done to figure out if a booster was necessary. And heard something about what the range was. I can't seem to find it, but my mom's antibody count was at 251. And that's the IgG. I went and had an antibody test done because I wanted to see where I was at. And I was pretty sure that I had COVID, got both shots of Moderna. My antibody count at that time was at 281. So, like, I have a very high antibody count. But as I asked my aunt, it's like, hey, what is there? What are you hearing about? What should it look like in terms of getting boosters? She handed me a bunch of really good articles to read, knowing that, I'm a well-read person in the scientific community. And one of the things that stood out to me was that we really don't have what we would consider an appropriate antibody range for diseases. And I'm kind of curious about what that means, for anybody who is and isn't considering a booster.
Yeah, absolutely. It's a really great question. I'm glad that it's evidence-based. So a couple things to keep in mind is, first of all, there is kind of a call for an international standard, and there was not necessarily a standard for here's the threshold for immunity, but early on in the pandemic, the World Health Organization standardized the units or international units for different types of antibodies for SARS-CoV-2, the virus that causes COVID-19. So that information is out there. I think a couple of things to keep in mind are, first of all, the FDA does not recommend the use of antibody tests to assess levels of immunity after vaccination. And there's a couple of reasons why. First of all, no two antibody tests are created equally. And a lot of them are not, it's not necessarily that they're approved or not approved. It's just a different process than, say, a vaccine or a medication or something like that. So some antibody tests measure antibodies against the spike protein. Some antibody tests measure against the nucleocapsid protein, which is another part of the virus body. the Pfizer Moderna vaccines are only authorized to, well, not authorized, they're designed to present a version of the spike protein on our cells so that we can recognize it. So if you are getting an antibody test for a nucleocapsid protein as opposed to a spike protein, you could test antibody negative after getting vaccinated. And that actually was a big problem when these vaccines, the second doses came out. People were like rushing to get the vaccines, the antibody tests to say, oh, did my vaccine work? And they were negative, and they're like, wait, this is ridiculous. So the vaccines don't work. And then, you snowball conspiracy theories from that. So a couple questions I'd ask was, do you know whether or not the antibody test you got was for IgG for nucleocapsid protein or for spike protein? That depends on the brand. The second thing would be, in general, even with that question, the FDA does not really recommend, saying, oh, my antibody level is X, therefore, you should get a booster. All of it is based on general risk factors for populations. So, the booster rollout has been recommended initially was recommended for high-risk groups. Now it's recommended for, I believe, all adults. If you are able to get a booster, it is recommended that you go get one regardless of your antibody count. So I don't know if that's a direct answer to your question about like what is the antibody standard. But the main thing is, according to those of us who have been studying for this virus and the epidemiology and the immunology for a long time, it shouldn't really matter. We recommend booster shots for those who are able to get them and those who are recommended for.
And that's the interesting thing too, is it's not just this particular virus that you have that issue with. It's every single shot, every single vaccine that we get. We don't have an antibody count or an antibody range that we actually study and that we're effective in, that we say is effective. And that was one of the things that I looked at too, because seeing that we don't necessarily have that for COVID, it's like, okay, well, do we have something like that for any of the other diseases that we get vaccinated for? And overwhelmingly, what I found was no, we don't actually. We just kind of understand like what the effective time range is of the vaccine or the booster that we get. For example, with tetanus, we know that we need to get it about every 10 years. And, it's just that, we recognize that about that point, that's when, we effectively start losing our ability to fight off the, tetanus. So do you foresee any type of push towards using antibody tests in order to figure out when it would be effective to get boosters, or is this going to be something where we're looking more at time-based data?
I think we're going to be mainly looking at time-based data and relativity data for now. I think in the coming years, because the reality is COVID is not going away. I think we talked about this the last time I was on the show. Like it's a pandemic now, but we're never going to eradicate COVID, the reality. I think over time there's going to be some more standardization because there's going to be these ongoing questions, not necessarily because it's been or is supposed to be standard practice in the field, but more it's just like COVID has thrown infectious disease epidemiology into the public eye in a way that's unprecedented for decades. And with all this access to, this is the first major, seriously global pandemic that we had major shutdowns for and everything in the age of instant information that we're at. So I think what's going to happen is people are going to have more interest and kind of drive the public demand for further information. But the other thing is that when you are testing for antibodies, it's not just like what antibodies are you testing for, what brand are you using, or whatever. There's also different methods that are like laboratory based. That when you're just trying to assess antibody levels empirically, there's different methods like ELISA, so enzyme linked immunosorbent assays versus neutralization titers versus there's ELISA spots. There's all kinds of ways to assess immunity. So it's not like and they will all give slightly different results. What matters is the consistency of those results in the units that are designed for those tests, and then tracking the trends over time. So, for example, there was a really famous study that was published a few months, about 7 months ago. It was in the age of, the second boosters had been authorized. People were wondering, did they work? And the major finding was those who were boosted had comparable antibody titers in general based on a particular method compared to those who had COVID and had one shot, but those who had COVID and had two shots were, had 100-fold more. So I think a lot of the discussion is going to be driven by fold increase because there are so many people doing so many different methods to assess antibody levels by their own, pick your favorite method here. I think the main thing is going to be the standardization is fold increase, like tenfold, hundredfold, thousandfold, based on whatever units you use, as opposed to, hey, this is the global standard, gold standard test that we're using across the world. We're just not there yet. Give it time, give it a little bit of a faded public scrutiny for a little bit this to be standardized out. And once we get more of a rhythm of how these COVID variants emerge over time and how to be prepared. So yeah, I hear you. You want to have a standard answer. I think right now, look at folds increase for, boosting, non-boosting, COVID, non-COVID, et cetera, over looking for a golden number by some particular method.
Mm-hmm. Now that's an interesting idea. So kind of moving on past that, along with the booster discussion, next question was, one of the things that I was reading up is that what they're finding is that with these vaccine shots, they're finding that people are having a variety of antibody responses that are allowing them to be more effective at fighting diseases beyond just COVID. And of course, falling down that rabbit hole, one of the things that I actually learned about is that there is a human coronavirus that's part of, our common cold complex. And so I was kind of curious, what does that look like, as we understand the vaccines now versus as, let's say as companies like Moderna build in their booster, seasonal flu and RSV vaccines?
Yeah, really good question again. So coronaviruses it's not just that this is a coronavirus that is the first time it's ever been called a coronavirus. We knew about coronaviruses for decades because, first of all, with SARS, the original SARS from the OG SARS from the early 2000s, but also coronaviruses are kind of part of the natural viral flora, if you will, that make up what we collectively call the common cold. There's rhinoviruses, enteroviruses, coronaviruses. There's all of them kind of kicking around, and a lot of them have been studied. And there have been recent studies. There was one that I pulled recently that's published out of Northwestern University that suggested some kind of possible immune crossover from COVID vaccines into at least one other type of human coronavirus. They isolated human serum from patients who had been vaccinated and looked to see whether or not they had antibodies that were sufficiently neutralizing against SARS-1, the early SARS virus, and then just the one type of common cold virus. And it showed that there was some COVID vaccination did kind of have a bleed over antibody neutralization effect. And then they replicated that in mice by actually doing some kind of prospective study, just vaccinating mice and exposing them to similar viruses. So yeah, this is going to be something that we discover more about. I think the evidence right now is trending in that direction, that if you vaccinate against one coronavirus, you're going to have some kind of crossover protection. But I think that's important to keep in mind is that, first of all, coronaviruses are an enormous family of viruses. They're very genetically diverse. And you think about viruses like, there's only one type or something else. We have more in common, humans have more in common with coral or plants than certain viruses have with each other. So just saying you have, there's some immunity to X virus because of this vaccine, that might be interesting, but it's not necessarily going to, it's not a panacea. It's not a coronavirus vaccine. The other question is, do we need a pan coronavirus vaccine? Because overwhelmingly, most coronaviruses that we deal with on a regular basis, at least pre-COVID, just cause, minor infection, minor illness. And it's really just, the juice is not worth the squeeze to make large batches of vaccines for those coronaviruses either. So I think there are going to be some interesting studies that continue to come out. Yes, there is some preliminary evidence that happens in some cases. I think it's promising to show as kind of an afterthought because Moderna and other companies are very heavily looking into RNA-based vaccines, like you mentioned, for like a universal flu vaccine as opposed to having to do an every year seasonal antigen-based flu vaccine. I think there's a lot of promise for those RNA vaccines, and this is one piece of the puzzle. But yes, you are correct. This evidence is coming out. I don't think the public should consider it as the COVID vaccine is the solution to all these viruses, but it's also, do we need a solution to all these viruses kind of thing?
Right. And I think that actually leads really great into another question, and that's talking about viral evolution. Because, as we look at, what the Spanish flu was, the fact that there are human coronaviruses out there, we do, as you kind of talked about, there is this viral evolution towards being less deadly. One of the things that we've kind of talked about in the past is that, especially with a new virus that's entered the human population, it's not that, whatever whatever evolves from the virus is automatically going to be less deadly. It's kind of a crapshoot. You end up with some viruses being more deadly as they evolve, and eventually finding a happy medium that doesn't kill the host. But then you also have other viruses that over time they become less deadly, and there's very, 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 very preliminary data out of Omicron that it's becoming less deadly. So maybe one of the things that I'm kind of looking at is, why do we approach these diseases with such caution first? And as each variant comes out, we don't just breathe a sigh of relief that it might be less deadly.
Here's an interesting thought. I would much rather have a virus that is way more deadly and way less infectious than a virus that is way more infectious and way less deadly. And the reason for that is, you think about, the percent of people who are going to die from a virus. Let's set up a hypothetical situation. And because we're just talking, I can't I would love to do this on like a whiteboard at some point, but the general thing goes like this, right? If you have a virus that can infect people with an R of 10, so for every one person that gets infected, they'll infect 10 other people, and the virus kills 1% of those people. Because it replicates and spreads to so many people so quickly, you're going to actually, most likely going to have more people die from that virus because of its higher infectiousness, its ability to spread. More people are actually going to get hit hard by the virus because an enormously large number of people are going to get it. Most people are going to be fine, but the actual objective number of people who are going to get very sick or die is going to be large. If you have a virus whose R naught is 1.5 and its lethality is like 10%, yeah, people who are going to get sick are more likely going to die, but fewer people are going to get sick. And there is kind of a trade-off where if you have a virus that's really, really lethal that does not spread too far, it's way less of a public health concern than a virus that is less lethal and spreads really far. And that is kind of exemplified. The real-world example is SARS-CoV-1 from 2003-2004 versus SARS-CoV-2, COVID-19. COVID-19 is much more transmissible, but way less deadly than SARS-CoV-1. Look which one is causing a massive pandemic, and we're about to hit 2 years. If not, we actually are over 2 years if you consider the Wuhan data. SARS-CoV-1 it didn't die out effectively. It had an R naught that was greater than 1. It did actually grow, but once we put in some control measures, especially in East Asia and in Canada, where we had a lot of people masking, lots of contact tracing, when there were fewer numbers of cases, all of that stuff worked out really well. It effectively stifled the pandemic, right? Not so much with a much more transmissible virus, and look at the public health burden. So when you talk about trade-offs and why are we not breathing a sigh of relief when we hear things are less virulent overall or less deadly, it's because there are concerns about if it is way more transmissible and vaccine evasive. Because if a strain comes out that is much more transmissible and tends to infect people who are vaccinated more effectively than previous strains, more people who are vaccinated are going to die. More people who are unvaccinated are going to die. And it's going to continue being a problem, even though, at some level, the virus might be less deadly. So it's a trade-off. It's the math. It's a kind of a balancing of your equations, right? There's a trade-off between the two. But that's why there isn't an instant sigh of relief, like, oh, it's less deadly, no big deal. Because transmissibility, infectiousness, the ability of a virus to spread is a very, very big concern, and is in some cases much more of a concern for the public health community at large than a virus that is very deadly in and of itself that does not transmit too well.
And so
my mind.
Basically, to really sum that one up, 10% of a very small number is a very small number, but 1% of a very large number is a very large number.
Very well said. Very well said. That's the bottom line of my diatribe there.
Yeah.
That just blew my mind too.
So now let's have a little bit more fun, because I think that there's some really neat stuff out there that we get to talk about in terms of we do talk about COVID a lot, but one of the things about vaccination I think is really fascinating is that, there's been a lot of work done, but there's been such an influx of money to help speed up technologies and speed up productions that there's some really cool stuff coming out there. So there's a couple that I want to talk about. One that definitely it won't affect me, myself, but it affects the relationships around me. And that is, how we've got vaccines developing for things like the new Alzheimer's vaccine that's being developed and tested. One of the things that I think is really interesting is that we have this giant fear around taking a vaccine for COVID because, well, the technology is too new. But for somebody like me who lost my grandfather and watched his life deteriorate as Alzheimer's took him, knowing that this new technology is potentially going to keep family members of mine from ever having to deal with that is really intriguing. So with things like the Alzheimer's vaccine, and I don't know how familiar you might be with this new one, what do you think people need to understand in terms of the concerns of being vaccinated for things we've never vaccinated against before, like Alzheimer's? It's not like a virus, like where we've vaccinated for the flu and other things like that. And I mean, vaccinating against a virus. This is, in a lot of ways, vaccinating against those things is something that we've done for 100 years or more in various ways. But for something like Alzheimer's, like what does that look like for people who are, afraid of losing their mind and their ability to function one day?
At Capella University, education is as smart as the world around us. With the FlexPath format, you can take classes at your own pace, set your own deadlines, and even leverage your previous experience to move faster. Now that's smart. Learn more at capella.edu.
Holidays are here, and so is fashionable fitness. Gift yourself a Samsung Galaxy Z Flip 3 5G, a phone that folds in half to literally stand on its own. Pair it with the Galaxy Watch 4 for ultimate wellness and wow factor. Check health stats, flex personal records. Over 90 activities can be tracked, like biking, swimming, golfing, and more. Invest in yourself with tech made to crush goals. Holidays open up with Galaxy. Shop it all at Samsung.com. 5G connection and availability may vary. Check with carrier. Products sold separately.
Hey everybody, my name is Jason from Public Access America.
My name is Adam from Adam Has a Beard.
My name is Corbin Elliott, and I am with the Peace and Purpose Podcast.
And you can find any of our podcasts anywhere you find your favorite podcasts.
Brilliant, gentlemen.
Hell yeah.
Awesome. Cool.
Thank you. Now we're going to dig it with a dab of double gooey doggerel. So cat swap off your whiskers and stretch out your fangs. And get with us interplanetary clamoroo.
Another fantastic question. You really came prepared. So let's back up for a second and talk about this new Alzheimer's vaccine that's kind of hit the news recently. So the idea of how it's supposed to work is that, so like you said, Alzheimer's is not caused by a virus or a bacterium that we could vaccinate against because of infectiousness. Alzheimer's is caused, or at least strongly associated with, chronic inflammation in the brain that is linked to what are called the plaques of these proteins called amyloid beta or beta amyloid proteins. And basically these proteins, for whatever reasons, build up in our brain. There's interactions between beta and other types of proteins. But the main thing is that it causes chronic inflammation, and that the cells in your brain that are not neurons, that are part of thinking and processing and behavior and response, but there's actually other cells in your brain that are supposed to clear out these, or are supposed to keep the brain clean, essentially, don't do their job as well with these plaques in place. And so the idea of the vaccine is, give the immune system something that will not recognize a pathogen, a viral pathogen or a bacterial pathogen that causes an infectious disease, but rather stimulates the immune system to recognize these plaques and kind of clear them out. And so it's a different twist on vaccines. There have been preliminary ideas for similar things like cancer vaccines that have come out. I think there was a couple of trials that were happening in Cuba, actually, for cancer vaccines. But I think it's important to keep in mind that, first of all, this is a phase 1 trial, right? There's probably going to be a few dozen participants that for the purpose of a phase 1 trial is safety and getting the dosage right. And then phase 2 and phase 3 trials are meant to look at the efficacy, how well the vaccine works. So this is very early in the technology. But moreover, I think it's important to keep in mind that even though this is a vaccine that is designed or believed to be intended for a condition or disease that is not an infectious disease, the process is very standardized for the management of these vaccines as they go through the approval process, right? So with the COVID vaccine, you mentioned offhand, I want to briefly touch on that. even though the COVID vaccines were people think that they were rushed or they were developed really quickly, the technology studying them was decades in the making. This mRNA, understanding how mRNA can be used, the technology behind it. What made it possible for that technology to be harnessed very quickly was, first of all, the brilliance of the scientists involved, but second of all, the process through which we analyze, review, and approve and authorize vaccines is very standardized, right? The way that we go through these phases of clinical trials, the way that approval happens, the way that emergency authorization happens, all that stuff is really well put together and is reviewed by scientists who actually really understand the data and understand the science behind what the vaccine is trying to do. And so if people are concerned about it, people are concerned about the vaccines or for whatever reason, the reality is that we are, and I don't mean to get overly patriotic here, but we are the greatest scientific and medical community in the world. We have the longest term, most reliable track record of putting out fantastic vaccines for all kinds of conditions. And through that process, we have refined our ability to go through these stages of trials. So if this vaccine falls flat, it's going to fall flat for whatever reason, it's going to be caught. And the reality is that this clinical trials process, most vaccines, most prescription drugs, most things that go into clinical trials don't actually wind up working because the system filters out those that are not safe and that are not effective very, very well. And that's something might be hard for people to stomach given, the EUA, the mass vaccination campaign of COVID, but the reality is every medication that your doctor's ever given you or every vaccine that has ever been able to be given to you has gone through a process like this that has been refined for decades and decades and has been improved upon steadily as the process has been executed and re-executed.
I think that's an important point. Yeah, the suitcase was already made. It was just what we put into it was innovative.
Yeah.
So to kind of make sure that we're very clear on this, we're not producing these plaques that would end up in the brain because that's one of the things that we constantly hear. Well, people who are vaccinated for COVID are getting COVID. No, that's not how it works. So the same question then: are people who are getting vaccinated for Alzheimer's going to get Alzheimer's?
No, if the vaccine, so to get a little more detail about the way this vaccine works, again, I am not an Alzheimer's expert. I did the reading through the original papers that published about this, the vaccine that was being trialed in mice and is now going to clinical trials. Other people are more expert in neurology than I am, and I'm just going to neuroscience than I am. I'm going to put that out there. But the way that this vaccine works is it introduces what's called an adjuvant, which is an immune stimulating molecule that is designed or intended to stimulate our white blood cells, which are our immune kind of boxers or our frontline fighters in our body, to recognize and clear these plaques of amyloid beta or beta amyloid proteins that build up more effectively. So it's not introducing like a component of the plaque into your body so that the immune system recognizes it more. It's actually designed to just be an immune stimulator in a different way. And that's the other thing about vaccine technology in general is that, no two vaccines are the same, and there's all kinds of different ways that we stimulate the immune system to do interesting stuff. The flu vaccine is designed, you introduce actually, antigens, components or fractionated components of a virus that cannot replicate into the immune system, into your body, so your immune systems, your cells can recognize it and produce the antibodies. With the COVID vaccines, the mRNA, Pfizer, Moderna, we're actually having our bodies temporarily make copies of those antigens, right? There are other types of vaccines that do different things. And so vaccine technology is highly varied, and there's no one single formula for how it works. There's no this is how the vaccine system works. This is how the vaccine immunostimulation process works. And that is all the more important for us to be upfront and open about the way things work, why it's important to read the methods of studies, and why it's important we have these clinical trials processes in place where so much of these trials are dedicated not just to the results but mainly to the methods. You can get your results if it works out, but were your methods robust? Did you have an appropriately powered study? Did you use appropriate formulations of the vaccine? Did you use the same formulation that you used in the preclinical trials as you did the clinical trials, right? A lot of the focus of these clinical study reviews for clinical trials are focused on the methods. I think that's an important point to keep in mind.
I love that. You told me once that it's almost like putting information into your body's library so that your immune system can access that information later.
Yes, yes.
So I love the analogies that you give me that I can carry on to people.
Well, I appreciate that you like them. I hope that they make sense, but it's always good to have a back brief, as it were, to make sure that what I'm sharing, I'm not just babbling. It's making sense to people.
So would the clinical trials include people that have these plaques or people that are looking to avoid it? So would it be people that have the pre-existing condition to get the plaques, or people that have overwhelming amounts?
I actually don't know. I'll have to get back to you on that.
I'm curious.
But the phase 1 trial, I think it's important to think in numbers, right? A phase 1 trial is dozens of people.
Right.
A phase 2 trial is dozens to hundreds, and a phase 3 is hundreds to thousands, right? So this is, again, extremely early on for this, the way this vaccine technology works, and it's only going to be a few dozen people. And the point of this is to make sure that you don't give people a vaccine and then they have very severe consequences. Right. It's not necessarily meant to assess whether or not the vaccine works per se. But I don't actually know whether or not it's like people who are pre-selected to have conditions for Alzheimer's. I think, if I were in charge of this, take that however you will, disclaimers, right? If I were in charge, I would only be having this vaccine. I'd be looking at people who are high risk, identified potentially for Alzheimer's. So, Jeffrey, you're talking about family history, right? Family history of Alzheimer's, that's a concern.
Not my family, but step family, but yeah, exactly.
Right. Yeah, like those are the people that I would want to target with a phase 1 trial, and at least for a first preliminary trial of these kinds of vaccines, especially given that it's like delving into very new territory. But I do not know for sure. I'll have to do another quick read through and get an answer to you guys.
I hope we can keep following this. It would be a nice story to follow to completion almost,
Give it a couple years. These trials take a long time.
Especially because this one is so new.
We'll keep podcasting then.
And that's one of the things is like, I know that, when we look at testing stuff, a lot of the times it's like, we're dealing with very healthy subjects, and there are people out there that have the precursors for Alzheimer's that are still very healthy. And so it would be interesting to be able to vaccinate people before they ever develop symptoms.
Yes.
Or like in some of the cases where I was reading where, mice that were affected with Alzheimer's after they got vaccinated started to show significant improvements and regain in function. So to me, it definitely, like, I agree with Dan, like it makes far more sense that, you would want to test on this particular population, because then the question is, do you really need to test on people who don't have that precursor? Like it's a very different story than like, dealing with a virus or like COVID or any other virus, where it's like, you don't have to have that virus. But like Dan said, you're not dealing with a virus, you're dealing with plaque and proteins.
Yeah, and I think more broadly, you talk about when talk about vaccines in general. Vaccines are only a very small point. It's the tip of the spear, basically, of a very large, I don't want to say the word industry, but a very large group of scientific expertise that studies a virus or a pathogen or disease in general, right? So you have, for every vaccine that's developed, you have years and years of preliminary research, basic science, understanding how a condition or a disease or a neuropathy or whatever works. And unfortunately, a lot of those scientists don't end up getting the credit or don't end up getting the hailing as, the heroism of those who finally developed the vaccine. But every vaccine is basically standing on the shoulders of giants, including the COVID vaccines, which everyone says they were rushed when they were really quick. Well, the reality is that it's pretty quick to take a piece of mRNA and put it into a micelle of glycolipids or whatever and inject it into something. It's very quick to make that technology, because we've been studying mRNA for decades. We've been studying nucleic acids like RNA and DNA for decades, and we really understand how to manipulate those well.
And the COVID virus, right?
And the COVID, and the coronavirus and coronaviruses in general,
right?
And more openly, this is not just for COVID, but for all kinds of conditions. There's a whole ton of research into all kinds of different research directions, where we understand the basics of how things work, and then once we understand the basics, then we start developing tools that are meant to be cures or preventions. Right. So, keep that in mind whenever we're talking about a vaccine. A vaccine never pops up right out of the blue, and the COVID vaccines did not pop up right out of the blue.
AstraZeneca was studying the coronavirus for 10 years or so. So, there was a lot of information for the suitcase, right?
Yeah, and Moderna was founded as a company based on not necessarily vaccine technology, but understanding the clinical utility of mRNA-based delivery technology, right? And that's been around. They've been around for more than 10 years, and they've been doing all kinds of exploratory work. They just happen to be thrust into the public eye when the emergency happens that hits the news. Right, and most times, if you're a scientist and you hit the news, something's gone wrong. But right, but that's the reality. Is that like behind every cure, behind every prevention, behind every prescription is an army of medical scientists who've been spending their lives studying a very, very specific either a process within the body or a very specific disease.
Now, I got a fun one because this one goes into something that I used to be very, very, very involved in. I love looking at so Biotech, for example, gene editing, things like that. There's so much possibility out there. Now, granted, my expertise was more in the agricultural end of things, but there's a lot that can still carry around. Now, one of the things that hit the news last week is that there is a vaccine that is currently being tested for valley fever. Now, having lived in Phoenix and know people that have dealt with valley fever is a fungus. The process that they used in developing this potential vaccine, that at least is for dogs, it's only for dogs at this point. What they did was they took the valley fever fungus. They gene edit it so that way it isn't deadly anymore. Then they reproduced that fungus and injected it into dogs to see if it developed an antibody response. Turns out it did. Then they took the actual valley fever fungus, injected it into dogs, and guess what? They had an immunoresponse to that fungus and they never got sick. So, number one, I mean, is this something that could be used to help deal with other potential fungal infections in humans? And number two, is there a way that you could potentially do something like this with other viruses as another means of vaccination efforts?
Jeffrey, you have stumbled backwards into the wonderful world of live attenuation. And which is a very standard practice in general, or I don't want to say a philosophy, but a methodological approach towards a lot of vaccines. So the idea behind live attenuation is basically that you take something that is really nasty, that can cause a nasty disease, do something to it so that it's less deadly or non-lethal or non-virulent, but still resembles the actual pathogen that causes the nasty disease, and use that to stimulate the immune system. And that's it, for fungal pathogens. I think that's really exciting and really interesting. I'll be very curious to see where this goes. But thinking about some live attenuated vaccines, that includes the MMR vaccine, measles, mumps, rubella, rotavirus, smallpox was a live attenuated vaccine, the oral polio vaccine, Flumist is a live attenuated vaccine, right? So live attenuation has been around for decades and is a very reliable kind of series of platforms for vaccination against all kinds of conditions, all kinds of infectious diseases. The downside, so the kind of the trade-off between that, so live attenuation is one major kind of school of vaccine development technology. The other one is based on just antigen-based vaccine development, where you just have pieces of the virus or pieces of the bacteria that are not lethal themselves or don't cause the disease themselves, but they're just kind of components that the immune system can recognize, right? Those tend to be a little bit less risky. And again, we talk about vaccine risk in a much more strenuous way than we talk about other medications. But those tend to be a little bit less risky because with every live attenuated strain of whatever, you always run the risk of, if people are really immunocompromised or some kind of gene rearrangement, if the virus allows for it, or there's always some freak stuff that can happen with a live attenuated pathogen that can potentially cause an infection from a vaccine. Right, and that actually happened with the early stage polio vaccines with the Cutter incident, where live attenuated vaccines were not properly quality assessed, and kids died from getting massive doses of polio from what was meant to save them from polio. But they tend to be more immune stimulating because those live attenuated pathogens kind of replicate a little bit in your body and then allow you to have a bit of a stronger immune response than just having an antigen injected into you, which can't reproduce itself. So you kind of, with a live attenuated strain, you're allowing yourself to get a little bit infected, not in a way that you can cause disease to yourself or to others, but just enough for your immune system to go, hey, this is actually kind of a problem, and have a bit of a stronger response than you usually get from just having a piece of your pathogen in the body.
So now, because being the kind of person that I am, gene editing has always been a fascination for me because of the potential that you can do with that. So a little bit of history then. How much in terms of live attenuation have we used gene editing? Like, at what point did we stop trying to quote unquote, partially kill the virus and start using gene editing in order to make this possible? Because there are going to be a lot of people out that are like, oh, gene editing, we're trying to make, oh, what was that fucking movie? I Am Legend happen. Like, when we all saw that fucking post go around, I'm like, oh, Jesus Christ, here we go.
CRISPR, right?
Is what?
CRISPR, yeah.
CRISPR.
That's one gene editing technology. I think this is a bit of one of those weird scientist leaning rhetorical questions. It's like, what do you call gene editing, and when you say gene editing, what is your definition of it? Because
I love that you're hitting on this.
Because strictly speaking, if you think about any kind of live attenuation, sort of you could make the argument that any kind of live attenuated vaccine has been gene edited, right? Any kind of live pathogen that you're using that's a live attenuated strain of whatever is gene edited. Now, did you use CRISPR or some other technology to kind of go and do surgery on its genome, like where you spliced at site A and site B to make something funky happen? Like in this case with this gene editing, they took out this CPS1 gene, which is known to modify the structures of proteins to make the virus or to make the fungus more virulent and cause it more disease, right? That's one type of gene editing. But the way that we make the flu vaccine, or generally, is you take a strain of flu and you pass it a bunch of times through an egg, and you let it infect a live egg, and then you take it out, and then you infect another live egg, and you take it out, and you basically force it to evolve to infect, right? Is that not gene editing, right? So because you're forcing natural evolution to try and simulate what will happen with multiple passages of infections in a human population, right? But you're forcing the virus to evolve. And with live attenuation, there's different ways that you can live attenuate. That's a pretty common one. But any kind of live attenuation is you're taking a virulent strain, a nasty bacterial or viral pathogen or fungal pathogen in this case, and making it less deadly. But the way that always works for life is almost always genetic, epigenetics, RNA, whatever. But at the end of the day, the way that you express, DNA to RNA to proteins, or in some viruses, RNA to protein, when you mess with that, that's technically gene editing. And how you mess with it, there's all kinds of different ways to do it. We just think gene editing in kind of popular science as like the slicing and dicing deliberately of, doing during the genome surgery. But that's only one small component of how the system works. The system, man, hits blunt kind of thing. But
Public Access America.
It's always funny because especially because as libertarians, we get a ton of shit, even amongst other libertarians.
I think political philosophy is a lot like religion, and where there's moments you have to go on faith and trust what somebody else is saying.
The main focus is just less dependence on the government, because we've seen how that's gone.
And you don't have to do that if you think about it in a human way.
More dependence on connections with each other.
You can always bring it back to what would one human do for another? What would 100 do for 100?
People looking out for people.
Find Public Access America anywhere you find your favorite podcast every Sunday and Thursday. And join the chat on YouTube at Public Access America every Sunday, noon Eastern, 9 a.m. Pacific.
Community's looking out for community.
Public Access America. History in the making, making history in the making, in the making, in the making, in the making, in the making.
Well, and that's where in the agricultural community, one of the things that we always talked about is what is a genetically modified organism? Because the fantastic thing is that the simple act of crossbreeding two potential species in order to create a more robust species of whatever it is you're trying to harvest is technically genetically modifying an organism, because you are specifically selecting the traits that you hope to get. It's just that, in one way, it's a very slow methodology, and what you're having to do is like, okay, well, I tried to crossbreed them, that didn't work. I got this really crappy looking cow. Another time you crossbreed them, it's like, oh, perfect. I got this, calf that delivered very smoothly, and then it turned into a giant bull that I can sell for a bunch of meat. It's
Jeffrey,
different.
Jeffrey, you're making me want a steak right now.
Me too.
Well, hell yeah. Well, then get a steak, dude. Like,
I hit up Longhorn Steakhouse last night and got a massive ribeye. It was great. Anyways.
Oh yeah.
So anything allowed to live is gene editing then.
Yeah, it's one of those things like you talk about, everything is a chemical. It's like, I'm not going to eat that. That's full of chemicals, right? Well, everything's a chemical. And
everything.
And to your point, I think it's also important to keep in mind that it's not. I think when we talk about gene editing, people are worried that the edited gene is going to do something funky to us. Mm-hmm. And that's kind of the source of it. And that's not really how any of that works. It's always like, for example, like you were in the agricultural business, Jeffrey. You obviously know about glyphosate resistance. Roundup resistance is one of the most commonly used genetic modifications in agriculture today.
Right.
The issue with that, or the rising concerns about glyphosate resistance, is not that there's a gene in the plant that causes the disease or makes you sick or whatever. It's that the plant might have residual levels of Roundup that if you eat enough of it, it might be a problem, right? And there's an ongoing debate about that, and there have been lawsuits settled, and there's some preliminary evidence, right? The jury's still a little bit out on that. But the point is that the discussion is not whether or not the gene is going to kill you. It's whether or not the gene allows something to happen that increases your health risk for another reason. And it's talking about like a mediation of like, it's talking about mediation versus moderation, right? You don't have A causing B. It's A is linked to Q is linked to X is linked to theta, and then theta is eventually linked to B, right?
Yeah.
And it's important for us to pause and be mindful of when we kind of slip into that mindset of, oh, it's easier to think about A causing B. Oh, the vaccine causes COVID, or the GMO causes cancer. Not really, right?
Interesting.
Exactly.
Rabies might eat cancer, but rabies will kill you.
And that's the thing. Like, everybody was so worried about these Franken-foods, like tomato plants were going to be walking the face of the earth, and you'd have these tomatoes like trying to eat people. Meanwhile, people were like just trying to figure out how in the hell they can make tomatoes grow better in cold environments, because guess what? Food scarcity is a real thing, and having the ability to grow foods in a variety of environments, especially in the face of climate change, is a very important thing to know.
Absolutely, and I think it's understandable. It comes back to kind of a common thing we've discussed about in our various podcasts. Like, people are going to have misconceptions or misunderstandings about science, right? Respecting the people for having those misunderstandings, right? Not thinking that they're stupid or lesser or they're idiots or whatever. And people just misunderstand stuff. I get stuff wrong all the time. My wife routinely reminds me about it, right? It's important to. But it's important to have those discussions in an open and free way, where it's like, yeah, let's break this down and have this realistic discussion. For example, I had a conversation a few weeks ago. It was actually, keep coming back to the COVID vaccine, but someone had a very serious misconception about, COVID had to be genetically manipulated in a lab. It had to be like a lab accident because it doesn't survive well on surfaces. Right. And then it was like, okay, let's break this down. And it turns out that the guy just had a really fundamental misunderstanding of how viruses can spread. And then we talked about how norovirus spreads and how hepatitis A spreads. And there's like, oh, yeah, it turns out And there was a discussion, and he learned something from it. I never tried to say, now, because we talked about that, you're now, here's the proof that you're wrong about your point. But sometimes it's good just to have a little discussion that leaves a seed of, hey, maybe I didn't fully understand the preconceptions I had that led me to this conclusion, and let them chew on it a little bit, right? So, yeah, I think that's important to keep in mind. So, yeah, just having a discussion about how it's actually maybe there's a mediation as opposed to a direct cause. Breaking that stuff down and taking the time is by far the most effective way to break some of these misconceptions. Being respectful and respecting people's intelligence, because people get stuff wrong all the time.
Yeah. I think, honestly, people have access to...
Jeffrey's pointing to himself.
People have access to so much information that sometimes it can confuse them when they don't have a certain degree in the basic understandings. I think we're getting overwhelmed on social media by a lot of facts hitting us all at once, and our brains just can't do that. So that's why I appreciate both of you for doing this in the right languages that we will see in these posts, but going on further to explain a lot of what we're reading.
Well, and that's one of the things that you and I talked about, Jason, was the fact that, I wanted to look at my antibody levels because, to me, what logically made sense is that if I had a high enough antibody level count, I should be fine when it comes to COVID. Sure. But in doing actual research and reading and finding out that we don't have any sort of, defined, this is the amount of antibodies that you need, or the specific antibodies that you need, or this, that, or the other. And that really it was more of a time-based function, and especially in the face of, something that is definitely changing. It's about knowing that you have a current set of antibodies that are able to fight off what the infection is going to be. And that, in and of itself is that, there's a lot of things about science where like we have some really neat ideas in the beginning, but then as we come to learn a bit more, it's like, okay, that doesn't hold up now in the face of what we're learning.
I do have an interesting question from this conversation. If there is a coronavirus that does mutate past the point of our vaccines to recognize it, would that be considered a different COVID?
Yeah. Oh, you're touching on another really funky subject that's kind of under the radar in infectious diseases, right? How we define species in bacteria, viruses, and strains and lineages, and everyone has or cohorts, or there's all kinds of languages that is kind of interchangeably used when you talk about different families of pathogens, right? One classic example is that there's E. coli, right, that causes really nasty infections, and then there's Shigella, which causes other types of really nasty GI infections. And everyone thought for the longest time that they were very different species. They look kind of similar and they functioned kind of similarly, but they were very different species, right? Then the era of genomics came out, and it turns out that Shigella and E. coli are close enough genetically to be considered technically the same species. But never tell that to somebody who studies Shigella for a living, because they'll get real butthurt, right? So, so that's a classic example. But yeah, that's a growing problem that we're having. And speaking as somebody who I do have a considerable experience, not just in infectious disease, but my subspecialty is genomic epidemiology, right? Using genomics to study the evolution of pathogens over time. Yeah. And seeing and associating that with transmissions, outbreaks, all that kind of stuff. We do need to get a better handle on what we call a viral strain versus a viral species versus whatever. I think what will probably happen is, for the sake of convenience, at least for the time being, we're going to continue going on with this like Greek letter alphabet and having variants identify and have SARS-CoV-2, kind of the original like Wuhan strain, be kind of the ancestral family, and just go forward with that. But how that fits in, and whether or not we're going to call SARS-CoV-2 a different species, or what do we call a different species or whatever, a lot of that in the microbial world has yet to be properly defined. With bacteria, it's like 95% average nucleotide identity across the entire genome, whatever. But viruses are a different beast, because there are viruses that have genomes based on DNA, and viruses that genomes based on RNA, and there are viruses that have RNA that's negative sense, which is different from RNA viruses that are positive sense, right? We generally talk about those viruses more broadly as like families or orders based on how fundamentally different they are in terms of their life cycles and what genetic material they're made up of and everything. So there is no clean answer. That's kind of the bottom line of all of this. But I do think that we're just going to continue having, calling it SARS-CoV-2, and then we've kind of established our standard nomenclature, the way that we identify different strains, this B117 versus B1617.1, and we're going to continue doing that, just like we've been continuing with flu. Flu has its own nomenclature for how it works. I think we're going to continue doing that. But when we call it a different species, I really don't know. Frankly, I don't think genomic epidemiology has been around long enough as a field to answer that question for just about anything, except perhaps bacteria.
Dan, before I let you go, is there any hopes you have for the holidays and the future coming up?
I hope that we continue to adjust to the new normal. And by that, I really mean just some general things that we're kind of amazed that we took for granted beforehand, like being allowed to just be at home when you're sick. Like if you're sick, being allowed to stay home, as opposed to having this, what we call in infection prevention, this bias towards presenteeism, right? If you're sick, stay home. and more people are getting normalized to that. I hope that we continue to adjust that. I think if people in our families are sick, you're being more careful, are being more attentive to like hand hygiene, like using, hand sanitizers and washing your hands more frequently. My hope for the holidays is that, as we kind of continue to adapt to the era of COVID, we continue to take that stuff more seriously, because it's not just for protecting ourselves against COVID, it's for protecting against flu, other types of common colds, also other severe infections, right? All kinds of things. Hand hygiene is the number one thing in infectious disease prevention that we talk about, because it's linked to just about everything, right?
That's right.
So my hope with the holidays is that even if we do kind of find a resolution where we kind of balance our lives more with COVID more effectively, with either better vaccines or a reduction in virulence or whatever, I hope we continue to take seriously some of the methods we have, because they're really useful to control disease just in general of all kinds of causes. So my hope is you guys continue to spread this message. My hope is that everyone has a safe and pleasant holiday. And I hope that people continue to want to have productive discussions about these evidence-based practices in medicine.
Love it. And you have yourself a very sterile Christmas too.
Have a sterile Christmas and cook your turkeys, cook your ham. Look it up. FDA has a model food code for how much you should cook stuff. Be careful. Don't need any parasites in you.
That's right. You can always visit our episode on Fred and food safety to find out more about that. How about you, Jeffrey? Any wishes for the season?
For the season, there has been enough. There's been enough division out in the world lately.
Yeah.
And my biggest thing is that for the holiday season, you look at what the least of your community has around you, and go out and try and do what you can for your community yourself. If that means giving to the food bank, if that means, you see somebody struggling to buy their groceries in the grocery store for holiday dinner, pick up the tab, if you have the ability to do it. Sometimes just being that one person that, gives somebody the chance to not have to choose between laundry and their turkey dinner for Christmas. It makes a huge difference for the family for that day. So I would say, just do what you can for your community. And if you see someone struggling, give them a hand.
Well said. Pay it forward. I love it.
5 Americans is facing food insecurity today. And that was statistics from before Mayfield. So remember that. Thank you, Jeffrey. And I'll say have a happy, whatever that happy is to you. Thank you for listening to Public Access America. We'll talk to you another time. Bye.
To those who would tear the world down, we will defeat you. This is our moment. This is our time. To those who seek peace and security, we support you. Yes, we can. And to all those who have wondered if America's beacon still burns as bright, tonight we prove once more that the true strength of our nation comes not from the might of our arms or the scale of our wealth, but from the enduring power of our ideals, democracy, liberty, opportunity, and unyielding hope.
Let me tell you something you already know. The world ain't all sunshine and rainbow. It's a very mean and nasty place, and I don't care how tough you are, it will beat you to your knees and keep you there permanently if you let it. You, me, or nobody is gonna hit as hard as life.
Ask not.
Yes, we can.
What your country can do for you.
I have a dream.
Ask what you can do for your country.
I, poor little children.
Yes, we can.
One day live in a nation where they will not be judged by the color of their skin, but by the content of their character.
I don't have to tell you things are bad. Everybody knows things are bad. It's a depression.
In this lifetime, you don't have to prove nothing to nobody except yourself.
But it ain't about how hard you hit. It's about how hard you can get hit and keep moving forward. How much you can take and keep moving forward. That's how winning is done.
Welcome to Public Access America.
Yes, we can.
Sunday live streams on YouTube.
I wanted to run out of that tunnel for my dad.
On Twitter.
What?
Apple Podcasts, Stitcher Smart Radio Public, and Spotify.
Yes, we can.
Public Access America. History in the making. Making history in the making.
Today's customers expect fast, personalized support. Intercom has the tools you need to deliver just that, efficiently, at any scale. Supercharge your team's productivity and make your customers super happy with Intercom. Learn more at intercom.com/support.
No one tries to be unsafe online, but during the holidays when you give up info and privacy, you may give up safety too.
Accept cookies to get holiday cookies? Okay!
Norton 360 with LifeLock helps keep your digital world merry and bright with device security, a VPN for privacy, identity theft protection, and more. No one can prevent all identity theft, but everyone can opt in to cyber safety. Visit norton.com/news and save 25% or more off your first year of Norton 360 with LifeLock.